welcome all of you to this masterclass case discussion. We have two faculty, and I'm very happy to introduce Dr. Sivaranjani. She's a final year MD postgraduate student. She's also done her dissertation under medicine unit 2, and I'm very proud for her to be presenting today afternoon's case. After she presents history, we'll have some questions. After we have examination, we'll have some questions by the two faculty. And then after the whole examination and diagnose over, members may put their questions on the chat box and we will take them one by one. So over to Dr. Sivaranjan.
Good afternoon, everyone. Am I audible? Audible. Good afternoon, everyone. I am presenting about this patient. 26-year-old Mr. M from West Bengal presented with difficulty in holding objects in his right hand since 9 years, difficulty in holding objects in left hand since 7 years, holding of fingers of right hand since 7 years, and in left hand since 6 years. He was apparently normal 9 years ago. Then, when he was studying 11th standard, he noted he could not hold a pen in his right hand while writing. And there was slippage of pen from his right hand with his awareness. There was also change in his handwriting noted in form of increased shakiness of words. He could not mix food properly. He could not button and unbutton shirt using right hand. He could not tear chapatis, rotis on his own. He was given in pieces which he could pick and bring towards his mouth on his own. The complaints were insidious in onset and gradual in progression. 1 to 2 months later, he could not hold teacup and other objects in right hand. He wanted someone to place his roti pieces in his palm. He also stopped using mugs while taking bath. Instead, he preferred direct showers for bathing as he had frequent slippage of mug from hand. 2 years later, he noted folding of fingers of his right hand and change in shape of his palm. Simultaneously, he developed difficulty in buttoning and unbuttoning shirts using left hand also, followed by folding of fingers in left hand also 1 year later. 6 months later to this, he also noted thinning of forearm, initially in the right side and then in the left side, which was slowly still progressive since then. 1 year later to this, he noted spontaneous involuntary contraction in right arm, followed by left arm. History of trembleness of both hands present. No history of difficulty in rising on forehead. No history of slipping away of slippers from foot while walking, buckling of knees, difficulty in getting up from squatting position. He is able to feel hotness and coldness of food when kept in palm. No history of numbness or burning sensation and pinprick sensation over the hands or forearm. This patient does not have any history of altered level of consciousness or fluctuating mood. No history of difficulty in perceiving smell, difficulty in vision or color perception. No history of double vision, drooping of eyelids, difficulty in chewing food, difficulty in perceiving sensation over the face, drooling of saliva while eating. No history of hard of hearing, tinnitus or spinning sensation of surroundings, difficulty in swallowing, change in voice, nasal regurgitation of food, difficulty in turning the head from side to side. He is able to feel clothes worn over his body, able to feel bites over his body. No history of stiffness of lower limbs. No history of swaying towards the sides while walking. No history of bowel and bladder disturbances. No history of trauma. No history of hyperpigmented patches, blurring of vision or sudden vision loss, fever, weight loss or loss of appetite. No history of night sweats. No history of recurrent abdominal pain, photosensitivity, skin rashes. No history of diurnal variation of symptoms. In the past, he is used to take complementary and alternative medications since childhood for minor complaints. And for the presenting above complaints, 6 months after the initial complaint, he started regular usage of TAM for almost 6 to 8 months. Since there was no improvement, he stopped using them. No history of trauma or diabetes, hypertension, coronary artery disease, CKD in this patient. Personal history, he consumes mixed diet, normal sleep and appetite, not an alcoholic or smoker, no history of high-risk sexual behavior. He stopped schooling at 11th grade due to the complaints. He had an average scholastic performance. Familial history, no history of similar illness in the family members. He is born out of a non-consanguineous marriage, second born. So I'm summarizing the history. Here is a patient with 26-year-old male with insidious onset complaint since adolescence. Developed gradually progressive distal weakness and thinning of bilateral hands and bilateral forearms with a loss of intrinsic muscle functions and deformity of hands and visible fasciculations with no higher mental cranial nerve deficits, sensory, autonomic or cerebellar symptoms with no similar familial history.
Dr. Jitendra, do you have any
Yes, sir.
questions?
Yes, sir. Yes, sir. So according to you, like this patient is having, you told it's a involuntary movements, history wise. So can you explain what is those involuntary movement? So we explain about the involuntary movements. What is exactly?
Involuntary movements, sir.
Yes, sir.
Uh,
What is the aggravating factor, any relieving factor for the involuntary movements? Where exactly it is noticed? At
Sir,
rest or any?
these involuntary contractions are noticed in the upper part of the arm, sir. There is no specific aggravating or relieving factors for that, according historically, sir. He noticed it randomly.
So you mean it's a, like a fasciculations? According to it's a fascicle, muscle fasciculations.
Yes, sir. When he told this history, I understood it as fasciculation.
Fasciculations. Okay. And what about the contraction? You told some deformity.
Yes, sir.
What are the deformities he's having in the hands? Like according to history wise, it's a flexion or extension. What kind of deformities?
He said there was a folding of the fingers in the in the terminal part of the finger, sir, right hand, and change in the shape. He described it as change in the shape of his palm. He lost the concavity of the palm, according to him.
Oh, okay, okay. Whether it start in the thumb first, whether it start in the little fingers, whether it's ulnar deviation or it's a median deviation. Any noting?
It started from the medial aspect, sir. Medial two fingers. He lost the. He developed a folding of the medial two fingers.
Okay, means according to it's like a claw hand. Looks like a claw hand. Is
Yes, sir.
okay, okay. Uh-huh.
Just some questions. So you think that he has got a which system is involved at the end of a history?
His symptoms are localized in the neurological systems.
You think it's motor, sensory, mixed disease?
Motors.
Predominantly motor, only motor?
Only motor, sir.
It's a pure motor disease from your history.
Yes.
At the end of a history, I think it's upper motor neuron or lower motor neuron?
Lower motor neuron, sir. Because the patient has given history of thinning, he doesn't give history of has noted thinning, and then he doesn't give history of stiffness.
So the lower motor neuron has many parts. Let's start proximally and go distally. What are the proximal most part anatomically of lower motor neuron?
It starts proximally with the anterior horn cell.
So tell us some anterior horn cell disease which could have caused this.
Segmental and ischemic anterior horn cell disease could cause. Otherwise, infection like poliomyelitis.
Polio.
Cause.
Okay. Any other disease can cause anterior horn cell disease? Not in India. Suppose he traveled somewhere, South America, Lyme disease. Then some people say that West Nile infections also can present with. In children, enterovirus 71 can have disease. Is there any other toxin or radiation which can cause anterior horn cell disease? So radiation, where the spinal cord is also injury, you can have anterior horn cell disease. So there are many diseases which can present with anterior horn cell. What is the second part of the lower motor neuron? Roots. Why is this not a root disease?
There is no specific.
You didn't mention radicular pain. So that's an important thing. What comes after root?
Plexus.
Why is this not a plexopathy?
There is no mixed presentation, both motor and sensory.
True. They usually have a diffuse pain over the plexus. Why is it not a nerve, peripheral nerve? Can this be a peripheral neuropathy?
But with the presence of fasciculation.
Fasciculation is not only present in anterior horn cell, no? Any lower motor neuron disease can have fasciculation. So what type of neuropathy will present with pure motor weakness? So there are pure
Hereditary.
motor neuropathies. Some are acquired, some are hereditary. You know some hereditary neuropathies? It's only 17. So that's something to look up. Hereditary motor neuropathies, hereditary sensory neuropathies, hereditary motor sensory neuropathies. He's 26, a little bit older, but he can still be having. What are the toxins which can cause toxic motor neuropathies?
Lead poisoning.
Lead. So how does a 26-year-old man from India get lead poisoning? What is the source of lead poisoning?
Water contaminated with
Water.
lead type.
Suppose he's got lead pipes, then
Paint.
paint,
Then working in toys.
toys, batteries, all those kind of things. So that's important history it could be. After the nerve cord, what comes next?
Neuromuscular junction.
Neuromuscular. Why is this not neuromuscular junction?
There is no diurnal variation.
You mentioned diurnal variation in your history.
Yes.
I think maybe you left that diurnal variation. Suppose it's other, they may not start off with diurnal variation. What are the other two major diseases which cause
myasthenia and
myasthenia and Lambert-Eaton? So does this man have significant loss of weight, loss of appetite?
No.
Forgot to ask that history. Significant weight loss, you'd say is paraneoplastic. Could be a Lambert-Eaton syndrome. He has got no cranial nerve symptoms, so we'll say probably may not be myasthenic. Can it be a pure motor muscle disease? Why is this not a myopathy?
Distal predominant myopathy is rare in this condition, in this age.
Distal myopathies are rare. All diseases are rare
in this age.
In this age. So which are the myopathies which could mimic this?
Congenitally, this Willander and Nonogaze.
You have to have some idea that it could be also a myopathy. This is more proximal or distal myopathy? If this is a myopathy.
Distal.
Distal myopathy. So which are the prominent distal myopathies?
Willander, Langs.
So to keep in mind that it could be myopathy. Does this chap have a frontal balding pattern?
No.
When he shakes hands, does he have difficulty in relaxing his hand?
No features of myotomy.
So you must go to all the pure motor syndromes. Does he have any neck pain?
No.
So cervical myelopathy also can present with this. Suppose a person has bilateral upper limb wasting. There's one particular sensory symptom which you have missed. Can cause bilateral motor wasting in the hands, but there'll be a particular sensory symptom. Touch will be preserved. They'll hold the hot glass, but their hand, afterwards they'll notice they have burns on their hand. What is that symptom? Searing. So what is that sensory loss called? Dissociate sensory loss. So the searings also initially, if you don't particularly get the history, you'll miss that this may be having a searings. So what were your differential diagnosis?
I'm localizing it to anterior.
Sure. Next slide. I think they have to. Can you? We have to go to the next slide. Yeah. No, it's there online. So your differential diagnosis was motor neuron disease. There are 4 types of motor neuron disease. Which type did you think?
Element onset.
So is this primary lateral sclerosis?
No.
Is it primary bulbar palsy?
No.
Is it pseudobulbar palsy?
I thought of element onset motor neuron disease.
So it's like a spinal muscular atrophy?
But there is no proximal predisposition. So I don't know that.
So if you put motor neuron, you must say what type of motor neuron disease. You said lead, but you didn't take history of lead toxicity. Porphyria. What are the clinical features of porphyria you mentioned?
Abdominal pain,
You mentioned abdominal pain. So abdominal pain. Second,
skin rashes, photosensitivity.
skin. Okay, very few people with which type of porphyria will present like this? There are two major types, no?
Erythrodermic and acute intermittent porphyria.
So acute intermittent porphyria. So erythromatous, they're different. Okay. Do they have psychiatric manifestations? Will they have change in color of urine?
Okay.
So when you say that, so when you put your differential, you should have asked for those histories in that. Paraneoplastic. What tumor do you think could be possible which cause paraneoplastic anterior horn cell disease?
Pulmonary.
You have to say something. You can't put you have to say, I think maybe. But then for that, your system review should have said you had cough or some small cell. Or if you thought of some other tumor, you must localize those symptoms as well. So this pure motor, you should go through all the parts of whatever possible pure motor and ask questions. Go on, examination.
On general examination, patient is conscious and cooperative and oriented to time, place, and person. He is a right-handed individual, moderately built and nourished. He is not paler, not icteric, not cyanotic, no clubbing, no pedal edema, no lymphadenopathy noted. No evidence of neurocutaneous markers, no peripheral nerve thickening, no hyperpigmented patches, nails are normal, gums are normal. Vital parameters, his pulse rate was 88 per minute, regular in rhythm, normal in volume and character, felt in all peripheral vessels, no radioradial or radiofemoral delay, no vessel wall thickening, carotid artery, no fluid. His blood pressure was 120 by 70, respiratory was 14 per minute, SpO2 was 98% in room air, and he was afebrile at the time of examination. Examination of the central nervous system, examination of the higher mental functions. He was conscious and cooperative and oriented to time, place, and person. His memory, immediate, recent, and remote memory were intact. His language was spontaneous. Comprehension is good. Fluency is good. Repetition and naming is good. Reading is also good. Writing couldn't be assessed. Speech was normal. Examination of the cranial nerves. Olfactory nerve was tested using coffee powder and asafoetida powder, which was normal. Optic nerve, visual acuity using Snellen chart and Jagger chart was normal. Field of vision using confrontation was normal bilaterally. Color vision using Ishihara chart was normal bilaterally. Fundus was normal bilaterally. There was no ptosis. Extraocular movements were full and smooth and full perceived. A normal saccade, no nystagmus noted while examining cranial nerve 3rd and 4th, 5th, and 6th. Pupils were equal in size, 2 mm bilaterally. Direct and indirect light reflexes are present bilaterally. Accommodation reflex, normal. Muscle examination of the trigeminal nerve. Muscles of mastication, no wasting, and he was able to chew. Sensory, touch, pain, and temperature. Checked in V1, V2, and V3 zones were normal. Right and left corneal and conjunctival reflex were normal. Jaw jerk was absent. Facial nerve, examining the motor part, there was a wrinkling of over forehead was symmetrical. Able to close eyes tight. Nasolabial folds are normal. No deviation of angle of mouth. Patient is able to blow the cheek and able to whistle. Sensory part of the facial nerve is tested by test over the anterior 2/3 of the tongue, which was normal. Vestibulocochlear nerve was tested with Rinne's test, in which bilaterally air conduction was more than bone conduction. And Weber test, there was no lateralization. Vestibular part, there was no nystagmus or no swaying. Glossopharyngeal and vagus nerve, there was symmetry of palatal arch and its movement bilaterally, and gag reflex was present. He was able to shrug shoulders against resistance bilaterally, and he is able to turn his head sideways against resistance. Examining the hypoglossal nerve, he is able to press against the protrusion of tongue is normal and able to press against the buccal aspect of the cheek and able to move tongue side by side. Moving on to the motor system examination. Patient is examined in supine position with bilateral upper limb on the side of the body, bilateral lower limb extended the knee and hip joint in supine position. On inspection, bilateral hand, there was partial clawing of the hands and thinning of the medial forearm noted, right more than the left, and fasciculations are seen in the bilateral arms. Bulk of the arms, bilaterally it was 24 centimeter, and forearm it was 21 centimeter, thigh it was 34 centimeter, leg it was 30 centimeter, bilaterally. Tone, upper limb, it was bilaterally hypotonic, and lower limb, it was normal. Examination of the power, shoulder joint, patient has a 5/5 power in flexion, extension, abduction, and adduction. And elbow joint flexion and extension is 5/5 bilaterally. Wrist palmar flexion and dorsiflexion 5/5. Examination of the intrinsic muscles of the hand. Dorsal interosseous bilaterally it was 2/5. Abductor digiti minimi was bilaterally 2/5. Lumbricals could not be examined as the patient had fixed hyperextension at the metacarpophalangeal joint and the flexion at the interphalangeal joints of the middle two fingers. Palmar interosseous, the bilateral power was 2/5. Opponent's polysis, in the right side it was 1/5, left side it was 2/5. Adductor polysis, it was 2/5 bilaterally, and Froment sign was positive. And examining the flexor digiter superficialis, medial two fingers, the patient had fixed flexion, and in the lateral two fingers, the power was 4/5. In the right side and the left side, it was 5/5. Examining the flexor digitorum profundus in the lateral two fingers, it was 4/5 in the right side and 5/5 in the left side, and the medial two fingers, patient had fixed flexion in the bilateral side. Flexor pollicis longus, examining was power was 5/5 bilaterally, and extensor digitorum, patient had a fixed extension at the bilateral side. Extensor digitorum minimi, power was 1/5 bilaterally. Extensor pollicis longus, power was 1/5 bilaterally, and extensor pollicis brevis, power was 2/5 bilaterally, and adductor pollicis brevis, power was 4/5 bilaterally. Abductor pollicis brevis, power was 4/5 bilaterally. Moving on to examination of the lower limb. Flexion, extension, abduction, and adduction of the hip joint 5/5. Flexion, extension, and knee joint 5/5 bilaterally. Dorsiflexion and plantar flexion of the ankle bilaterally, it was 5/5. Reflexes, superficial reflexes, abdominal and bulbocavernous reflexes were present bilaterally. Deep tendon reflexes, biceps reflex was preserved bilaterally. Triceps and supinator reflex were absent bilaterally. Knee and ankle reflexes were preserved bilaterally, and plantar reflex was bilaterally flexor. Sensations, pain, temperature, vibration, fine touch, and joint position were intact all over generally, and examining the peripheral nerve at the ulnar distribution, median distribution, and the radial distribution, it was intact. Examination of the cerebellum, patient was able to do finger nose test, finger nose test, and knee shin test bilateral, and his gait was normal.
Other system examination.
Systemic examination.
Okay, she's forgotten other system exam because you said one of your diagnosis paraneoplastic, but you left out the other systems. Okay, let's leave out that for the second. At the end of your history and physical, is it LMN? Is it UMN?
Element.
Contractures develop commonly in LMN or UMN?
In UMN only, but
More in UMN, but you said that the person has bilateral contractures. What are the reflexes?
absent. Triceps and supinator were absent, sir.
Okay.
Bicep was preserved.
So let's go back. Why did you say anterior horn cell disease?
The patient had a wasting and
Wasting is
We
again
get the-
lower motor.
LMN with the fasciculation.
Only the fasciculation tells you this is anterior horn cell disease.
If
I'm
it's
saying in your history wise, an examination, the only pointer bilateral upper limb wasting, you're saying the only feature is
there was a pure motor
pure
syndrome
motor. Yes.
in that
So
either it should be a
the pure motor. I'm asking which is it? You said it's LMN. So anterior horn cell, you put one. Could it be a root? Unlikely because there's no sensory loss, there's no radicular pain. Could be a pure motor neuropathy. Was there a wrist drop?
no, sir.
What are the skin manifestations of lead poisoning?
There will be Bartonian sign in the and then in the
Okay, then can B12 deficiency produce pure motor neuropathies or pure motor syndromes? Can have. Or there any clinical features of B12 deficiency?
No.
Is there any other deficiency which appears like B12? So copper deficiency. So are there any clinical features, anemia?
No, sir.
That's very
Yes.
important. So you must look for these. You mentioned neurocutaneous markers. What are the neurocutaneous markers you look for?
Calculates.
Are you thinking of? So you should have mentioned common cutaneous paraneoplastic manifestations. Can you tell 4 or 5 cutaneous paraneoplastic manifestations?
Acanthosis nigrans.
Acanthosis nigricans can be there in many conditions, yes.
Palmar
Palmoplantar hyperkeratosis. Then hyperpigmentation by itself. Which tumor?
adrenal tumor.
Adrenal tumor? No. Usually small cell carcinoma lung which produces MSH-like substance. Along with that, it can cause. Can there be Cushing's? Why? Some lung cancers produce ACTH-like substance. For that, you must go one by one. That there are many paraneoplastic cutaneous manifestations. Okay. So you said anterior horn cell disease. Then one of the things I asked you about is cervical spine, cervical myelopathy. Do you know any CV junction anomalies, craniovertebral junction anomalies? Some of them also can cause compression of the corticospinal tract, and it can be purely motor. So one of the examination findings we should have mentioned is the neck height ratio. All right, so that's important. So pure motor you left out.
Yes.
So pure motor neuropathies we have discussed. Clinically, how do you know this is not neuromuscular junction? How do you check? What are those tests which you can do on bedside? Anybody? Sorry? Single breath head test. Look at, so you must read up how to do an examination, because the exam pure motor you have to examine and say that this is not neuromuscular junction. Could this still be a muscle disease? How come it's not Becker, Duchenne?
Proximal involvement is not proximal muscles power stressor.
So I'm saying, could this be a distal motor muscle disease?
Reflexes.
So now the next question you came, you said reflexes are diminished. When do reflexes get diminished in anterior horn cell disease? You show us your reflexes. You said the triceps is absent, supinator is absent. So are they an early feature or a relatively late feature, the absence of reflexes in?
Late.
So that's an odd feature. So you have put your diagnosis as anterior horn cell disease. What is the etiology of the anterior horn cell disease according to you? There are many causes of anterior horn cell disease.
Be early onset LMN, early presentation of the LMN onset MND.
So this is an LMN MND.
It could be segmental ischemic like Hirayama.
So you thought this could be Hirayama's disease. Okay. Any other diseases?
Other variants are not. Patient doesn't have any other.
What are the variants of MND?
Kennedy's disease.
What is Kennedy's disease?
Patient will have gynecomastia and then infertility.
But you mentioned about gynecomastia. Is he married?
No, sir.
Does he have absence of secondary sexual characteristics? You forgot to mention that. All right. Any other variants of MND, you know? SMA. All right. So let's see your differential diagnosis. What have you put down? So your differential is segmental ischemic Hirayama. What is 3? You have put a dotted line.
Now, after the examination, I have first 2 I'm.
Now, what's your third differential? You left it blank. You should not have the exam a differential which is no differential. You have said lead poisoning. If you put lead poisoning, then you should have told clinical features or absence or presence of lead poisoning. Porphyria you put down. but you didn't say anything about skin manifestations. You put on paraneoplastic. Again, you didn't justify why you said paraneoplastic. No, there's no significant loss of weight. Doctor, you have any other questions to ask? Dr. Jitendra, any questions? Okay. How would you like to manage this patient?
Sir, first I wanted to assess the baseline characteristics. So I
It's the wrong thing. You should never say, I want to do general blood test or general anything. Always the management in general medicine is specific to your differential diagnosis. First, you want to confirm your diagnosis. So what is how do you want to confirm motor neuron disease?
I want to go with EMG.
EMG. So what will be the classical EMG and EMG NCV finding? EMG is myogram, no? So what is classical finding in anterior onset disease?
There will be chronic denervation with reinnervation.
Chronic denervation with reinnervation. Okay.
Picket fence appearance.
Picket fence appearance. So you should be careful because part of your MD syllabus includes interpretation of EMG and NCV. So if you say anterior onset, in the exam they tend to think of this as an easy case. There's only one motor, it's lower motor. You just have to discuss lower motor neuron. So that part you have to go a little bit more in detail about. If you confirm it is anterior onset, what other tests you'd like to do? Before you label that it is a familial or sporadic disease. What are the infections you want to rule out? Lyme disease is not there in India. I mean, maybe some rare place. HIV? Syphilis? Okay. Any toxins?
Heavy metal.
So lead poisoning. Then any other, you said hyperpigmentation could be there in which disease? B12. Copper? You must check for copper levels. Paraneoplastic, how will you do? What workup will you do?
Cross.
So you have to say in the exam. You can't say cross-section. What will you do? X-ray chest or ultrasound abdomen? What will you do? So most people will do a CT of the neck, thorax, and the abdomen. After that, if you're still having high suspicion, then you'll do a PET scan. Okay. So we have looked at that. Could this be a vasculitis? Could be. So you must have a thought about that. Could this be Hansen's disease? You said the patient has no thickened nerves. The patient's not here. We can't examine. But anybody with claw hand in India, one of the infections to rule out is
Leprosy.
Hansen's disease. So you must look at that. So like this, you must start off with all the possible pure motor syndromes. Could this be a bilateral cortical infarct or cortical disease causing a pure motor disease?
Insidious problem. Very slow.
Only that will be upper motor neuron kind of picture. That's why you're saying it's only the. All right. So how would you suppose it is confirmed as motor neuron disease? What are the treatments available for motor neuron disease? Riluzole. What is the class of drug of riluzole? Anybody? NMDA or something? I think it's anti-NMDA.
Anti-glutamate.
Glutamate drug. Suppose he has spasticity of the fingers. Any drug you want to give? Pacitane is not given for this. Any other? For spasticity in upper motor, what do they give usually? Tizanidine, baclofen can be given. He has pain. Huh?
No, sir.
No pain. Many people with motor neuron disease tend to have emotional instability. So what drugs can you give for that? So second generation antipsychotics can be given. They also tend to have frontotemporal dementia. So did you check carefully for memory and other things? So we didn't want to go into that. But that is another thing you can do. You can do a formal memory assessment. You may want to do the imaging of the brain. Do you think that this could be a CIDP? Pure motor CIDP? I'm just asking you a question. So you must think about that if you suspect. But it's unlikely. There's no sensory symptoms. So then you may want to do a CSF and testing of the CSF. Can you use it paraneoplastic? There are two type paraneoplastic tumor antibodies. Can you name some? Because you said I'm going to test for paraneoplastic. What are the common antibodies for tumor? Anti-neuronal antibodies seen in people with tumors. Rho, Li, U antibodies are there. Those are anti-nuclear, anti-cytoplasmic, or those are again the neuron cell body and the nuclear part of it, U, D, and La. And they're usually seen in what tumors? So lung is one of the common manifestations of those tumors. So anyway, if you have a pure motor syndrome, make sure that you don't not missing out copper, B12 deficiency. There are so many other motor neuropathies which are toxin mediated. So especially you said the history of taking alternative medicines. So you must learn to list out those diseases. Don't put all your eggs into the basket of motor neuron because there's fasciculations. Fasciculations could be there in many diseases. Absence of fasciculation, how would you bring out fasciculation? You think that this is motor neuron, but there's no fasciculations. How will you bring it out?
Repetitive making to
Repeated movements means you will make him do flexion, extension, and then hyperventilation, tapping on the muscle. You can give some drugs and all, but nowadays nobody gives some drugs to enhance that. Okay.
And sir,
Yes, please go ahead.
yes. So is there any other differential diagnosis for this claw hand the patient is having? So it's like now as of now it's a like MND element type. So and with some pure motor. So any other differential diagnosis you want to think of in these patients? What are the cause? What are the cause for claw hands? And in sensory also it is like a motor. It is a ulnar part is more affected compared to the medial part. Is there a simple like peripheral neuropathy motor the compression towards the bilateral any ulna or median entrapment syndromes? So entrapment syndrome that is also can think of.
Okay, sir.
Okay. And multifocal motor neuropathy with conduction block that is also young patients presents with bilateral distal involvement. So these are some of the differential diagnosis you can consider.
Okay.
Which part of the compression of the brachial plexus can cause ulnar clawing? Which of the roots?
C8, T1.
C8 and T1. What are the diseases which can cause C8, T1 compression? Brachial neuropathies, clump case, or there's a tumor, mostly lung cancer.
Pancreas.
Upper lobe lung cancers, which can cause compression of the lower brachial plexus. Only thing is here it's bilateral. It's unusual.
Yeah.
Can be there. You had some fibrosis or tumor bilaterally. Those are a bit unusual, but also you must consider that. Okay. Sir, any other questions?
Investigation, sir? Is there investigations done for this?
You have put up any investigation?
Yes, sir. EMG of this patient is done. I have put up the EMG of this patient, sir.
Okay.
And then the MRI There is hyper.
No, go back to that. Actually, in the exam, you won't be given the EMG of the patient. You will be asked to tell your test which you want to do. And then if you ask, and then they will give you some interpretation of that. So here in this case, we're discussing slightly differently. So how in a axonopathy from demyelination, how do you differentiate on EMG?
Increase the amplitude will be increased in the axonopathy.
Axonopathy, the amplitude will be increased.
Latency will be decreased.
And demyelination? Okay, let's ask Tony. Tony is not. We'll ask. What are the PGs? Yes. Anybody? Raj? Amita? So you have to know these. Akash? Okay, so that's a homework for all the PGs here. You have to know axonal from demyelinating. Any peripheral neuropathy, first thing you have to ask axonal demyelinating, and you must be able to differentiate. If you say it's a anterior onset disease, you must know the classical picture of EMG and NCV. Okay, so this C7 to T1 cervical myotomes seems to be involved in this EMG pattern. Okay, shows the MRI picture. Why none of your differentials involved cervical compressive myelopathy? You didn't involve any CV junction anomaly.
Right.
Why are you showing us the MRI picture?
There was segmental involvement, so.
No, your clinical diagnosis did not involve that. No. So always go by your clinical. If your clinical was not cervical myelopathy, then you won't have ever imaged the spinal cord. So whoever this doctor who saw this patient included the possibility of cervical compressive myelopathies or a CV junction anomaly, and therefore has taken this. What is the classical clinical picture of somebody with of eye movement abnormality in somebody with a CV junction anomaly? One type of nystagmus, foramen magnum lesions.
Competing.
Downbeat nystagmus. Okay, show us the MRI. What's your interpretation of the MRI?
Hyperintensity in the C6, C7 T1.
Okay, can show them the pointer so the people can make out that. What is that? You're showing us the.
Is it a component?
It looks. That's the vertebral body, or what you're showing us is the vertebral body.
Yes,
I'm asking
Yes,
the spinal cord. See, this is the
spinal
spinal
cord.
That's the spinal cord. No. So something has happened here, and this is spinal cord here. This image may be a bit of a. Sometimes in the rotation, you won't get the good image.
Okay.
So I have a feeling that we have missed the full look. This looks like more like a compressive myelopathy, though we can't see clearly. Something has happened to the cervical vertebrae also. But it may be just that the image has got rotated a bit and appears. Otherwise, it appears that the vertebral body seems to be quite something has happened to them there. But I'm not an expert in interpreting cervical. So that is something. Let's ask the other PGs. Suppose there's a CV junction anomaly. What are the clinical features you look for other than neck height ratio, platybasia, or what are the other CV junction anomalies you know? Sorry? Arnold-Chiari. So is there any particular clinical features one must look for? So there's a couple of lines you must learn to draw on examination between the eyes and ears and other things. So all of you must go back and look at those. Why would you look at the fundus? If you think of CV junction anomalies, particularly Arnold-Chiari malformation, why would you look at fundus? Raj? Raised ICT, why? Because they will be, what do you say when the medulla comes down through the foramen magnum? What is that called? herniation, and then that will cause compression of the central canal and hydrocephalus. So looking at, if you see papilledema in somebody with cervical myelopathy, worry whether there is evidence of CV junction anomaly, Arnold-Chiari malformations. So those are other things to look out for.
And cranial, when you talk about cranial also, so like high cervical cord lesions, you have to carefully look for the trigeminal. So it's a spinal branch of spinal nuclei of the trigeminal, so facial involvement, facial sensation also impaired. So that also you have to mention when you think about high cervical cord lesion, CV junction anomalies.
So let's ask some more. What is the pattern of sensory loss? Facial sensations on the face are lost. There's a particular pattern, it's called.
Onion.
Sorry? Onion bulb appearance, yeah, from the nose. There's another pattern, Roman helmet, balaclava helmet, or balaclava helmet appearance. So that's because the spinal nucleus comes down through the fifth nerve. So these are the differentials to consider. Okay. I would also do the simple test first, like it's pure motor, make sure B12 levels, copper levels, HIV test. You mentioned porphyria. What are the tests you'll do for porphyria?
Urine. Porphyrin.
Urine, porphobilinogen, urine porphyrin, porphyrin. What are the tests?
Urine porphyrin.
Okay. What about you want to do some genetic tests? You said that this is a MND. What percentage of motor neuron disease is acquired? What is congenital, hereditary? Are most of them sporadic cases? Or should you do testing his parents, brother, sister, mother, everybody?
Sporadic.
90% are sporadic. So doing this genetic test, if you unless you have a strong family history, may not be of any benefit to the patient. So what are the major is Riluzole a very magic drug?
No.
So what are the major therapy we can offer him?
Occupational anesthesia.
Yeah, so he's got contractures. So to see whether surgical release of contractures is possible. Then it's all about occupational therapy, physiotherapy. If they have fatigue, many people with MND have unexplained fatigue. You can give some SSRI for the fatigue. Check for any other treatable illnesses and treat them. And it's mostly about care like that. It's also about long-term care, telling the progression of disease, what to expect in the future, and how to manage that. Are there any questions from the online audience?
So, can you have heard of Madras motor neuron disease? This is one of the variant of MND, Madras motor neuron disease. Have you heard of? And so it typically affects in the young male patients. So it's a very slowly progressive distal involvement. Sometimes they can have associated with the eighth nerve involvement also, 1/3 of the patients. So okay, typically seen in South India. Okay, so those are the things also you can consider it.
Okay.
This is one of the variant of MND. So they can have impaired glucose tolerance.
Are there any questions from the physical audience? See the chat box. Okay. Since there are no questions from the online and offline audience, I think let's give Dr. Shivaranjani a big hand. She's done very well. The exam, though, I think that you should be a bit careful. This is considered a very easy case. So you have to be prepared for detailed questioning. Complex cases, you sometimes think you didn't do well, but it's complex. So the examiner itself thinks making a localization, etiology is difficult. So you may do better than what appears to be a pure motor syndrome, which you may be asked many questions and in-depth questions. So you have to be careful about that.
Okay.
That's well done. Thank you, doctor. Thank you for coming
Thank
from
you.
all the way. It was a pleasure.
Thank you, sir. Thank you.
Okay. All right. Thank you, guys.